Hello, welcome to the third part of this series on bone scintigraphy in nuclear medicine. Today we're going to talk a little bit more about metastases, and also we're going to discuss briefly the important topic of chemotherapy response. So, in the last video we spoke about metastases as random focal areas of uptake in the skeleton, but what happens when a patient has widespread metastatic disease? The number of metastases can be very great, like this patient here who has extensive metastatic prostate cancer. But you can see that we're still able to identify some, at least, individual metastases in this case, multiple focal areas here, but you can see how they are just about beginning to blend in together. You can also see there's relatively little activity in the bladder here. The technologist hasn't had to put a region of interest here to obscure the activity, and we're not seeing very much renal activity. Now, this is an appearance called a suprascan. So we have widespread activity throughout the ribs, spine, focal areas in the humeri and femora, but the impression is of lesions coalescing together so they form one homogeneous area of increased activity within the axial and proximal appendicular skeleton. And what we mean by that is spine, ribs, pelvis, and proximal long bones. Essentially the area where an adult patient will still have some hematopoietic marrow. So it's called, as I said, I don't know whether it's called suprascan or suprascan. Different people say different things, but I'm sure both will be correct if you should use the terms. Now let's have a look at the plain film of this patient. Often you have very extensive metastatic disease, but despite the very abnormal bone scintigram appearances, this patient only has a few sclerotic areas here. Maybe this, that could even be normal. This area here looks a little abnormal, and this certainly looks abnormal. So, although you often see very abnormal radiographs, that's not always the case. Now, here's a patient who has a more diffuse example of a suprascan. Again, we've got almost no bladder activity, very little renal activity. And this case actually you might find a bit more difficult because there are very few focal lesions from which to make your diagnosis. Just a general pattern of diffuse increase in activity within the axial skeleton and proximal appendicular. And it's often this junction here, the crossover point between the abnormal bone and the normal bone, that can help you to make the diagnosis. Suddenly you just can't see the legs at all. But this can be quite difficult to interpret unless you have some experience. So just be careful that you always think about it, especially if you're dealing with a patient who's got a very abnormal CT scan, grossly elevated PSA. Just look carefully and ask yourself, do they have a suprascan, and is it just that the entire bone marrow, is it that the entire bone is actually abnormal? Looking for the kidneys is very helpful. Now, although suprascans can be seen in extensive metastatic disease, I'll just have to remember to point out to you that they can be seen in other conditions, such as renal osteodystrophy and also in hyperparathyroidism. Now, you may well have a pretty clear history which will give you a diagnosis of either of those, but you might be doing a bone scan on a patient with hypercalcemia where metastases are being suspected, and you don't want to miss the fact that it's actually due to hyperparathyroidism. Similarly, you might have a patient with renal osteodystrophy. Their bones will be abnormal on other imaging modalities because of the renal osteodystrophy, and you have to be very careful that you don't accidentally jump to the conclusion that they have metastases. So the patient we've just seen here, I'm just going to show you his plain X-ray just to show you how grossly abnormal it can be, and this is the usual appearance that you'll see in a suprascan if you should care to do a plain radiograph. Quickly, just to show you a normal one, this is the very first bone scintigram we saw in our first talk, and just to put that next to what I consider to be a reasonably subtle suprascan. So we've got some bladder activity. Kidneys, I can't really see much activity here, and don't forget you should obviously look for the kidneys on the posterior view because they are posterior structures and so will be seen best on that. But you can just see this predominance of the activity in the pelvis, ribs, proximal humeri here, and the spine, compared with the more even distribution that you see in the normal case. So this is the normal bone scintigram here, and this is the suprascan with the absent renal activity and centralization, axial skeleton, pelvis, ribs, proximal long bones. They're the places you need to look for if you're thinking about a suprascan. You can actually see markedly increased activity in the skull. Some people say that the presence of the activity in the skull, the predominant skull activity, is more common in what's called a metabolic suprascan. That is a suprascan due to renal osteodystrophy or hyperparathyroidism. Now, apologies that this quality of this image is not very good, but I just want to show you one other, if you call it a metabolic or rather a hematopoietic bone condition which you might mistake for suprascan. In this case, the intense activity is seen around the epiphyses, and this is a pattern of uptake that is seen in extramedullary hematopoiesis. So you might see this in polycythemia or myelofibrosis. And what's quite interesting about this is these patients will have widespread marrow reactivation, so they will have very abnormal looking MRI scans, and somebody might report an MRI scan showing very abnormal signal because of marrow reactivation, and then they might say, oh, let's do a bone scan to see what's going on. And you don't want to report this as metastatic disease. You want to make the correct interpretation of extramedullary hematopoiesis. So if you see this, go looking for an underlying diagnosis like polycythemia or myelofibrosis. Now, I did mention hyperparathyroidism, so I just thought I'd throw this picture in here. Hyperparathyroidism can also cause multiple focal areas of increased activity, not in a dissimilar pattern to metastases, but the uptake is a little more random, so it's rather unusual to have, although not impossible, to have metastases in these odd positions. This is a patient who had multiple brown tumours from hyperparathyroidism. So if you're doing a bone scan for a patient with unexplained hypercalcemia, just remember to consider that before you suddenly jump in and give the patient a diagnosis of multiple metastases. And remember that it's not always the case that the patient's calcium is high and the serum parathyroid hormone is high to make a diagnosis of parathyroidism. It's possible that there may be a normal level of parathyroid hormone and high calcium. That can still be due to hyperparathyroidism. Really, what you should see in a normal patient, if their parathyroid glands are responding correctly, a high calcium should cause their parathyroid hormone to be suppressed. So just because the parathyroid hormone is within normal levels and the calcium is elevated, don't discount the possibility that the patient may have underlying hyperparathyroidism. Okay, so we've seen a couple of sternal abnormalities already, but I just thought we'd get through a couple here. So we saw that there's normally a small area of focal uptake at the manubriosternal articulation. That's a normal variant, but also we saw the transverse band of activity from a fracture. Now, if you look in this case, you can see it's quite asymmetrical, with slightly more prominent activity on the right-hand side compared with the left. This is the classic appearance you see in tumour spread from breast cancer, and it's nearly always an ipsilateral one. So the patient will almost certainly have a history of breast cancer on this side, and I don't know if it's nodal spread or some other type of lymphatic spread, but you see the tumour here on the same side of the sternum, causing an abnormality on bone scintigraphy. And we can see the sclerotic abnormality here in the sternum, and it's quite often missed, actually. This patient obviously has a large pleural effusion as well, but the metastatic disease in the sternum can be missed. And if it's an isolated deposit, the patient may be a candidate for a resection of the sternum. So it's worth picking up. Let's just do a couple more sternal abnormalities. And this is just another point that I wanted to make. I could have made it earlier, but I thought this would be a good place to mention it. It's a concept called shine through. So you might have seen it on some of the pictures I've shown earlier, but sometimes if there's an area of intense activity on, for example, the posterior view, the gamma rays which are emitted from the tracer, from the focal area of accumulation, will in addition to activating the posterior camera head, also pass through and activate the anterior camera head. That's called shine through. So that is, in effect, a posterior lesion, the activity being seen posteriorly, but also shining through to the anterior camera. So it's seen on anterior and posterior camera heads. Now this obviously causes a problem because, of course, it might be difficult for us to localize the site of the activity, and here's a case in point. To me, on the anterior view, this looks like a sternal lesion quite clearly, but in the posterior view, it looks more like a vertebral lesion. So which is it? And it might be important because the clinician might say, I need to know where I'm going to give the patient radiotherapy, so they might want an answer from you. You can see a rib metastasis here. That's seen in anterior and posterior views as well. So this is also shining through, as is this degenerative change in the shoulder joint. So, of course, what we can do quite simply, we could do a SPECT-CT examination, but we can also do an oblique view, and that shows that the abnormalities within the spine and the sternum is normal. So an oblique view is sometimes useful just to not to get caught out with shine through, and that's what the concept is. A couple more sternal things here. So here's a patient just from earlier on today, actually, before I made this talk. And the patient has a couple of things. Small focal area of increased activity here, just below the sternum. And you probably can't see it, but you will in a minute. A very faint area of lucency in the lower sternum here. So I was just a bit concerned about this small spot. It's usually due to the fact that the scapula is overlapping the rib, causing some increased activity. But I just thought we'd do an arms up view, like this, just to check that scapula and rib were okay. And that does look fine. You can see that area of prominent activity is still there. And you can see this lucency here in the lower sternum. So I know what these are, and I didn't need to investigate them any further. But here's just from another patient, just to show you what they are. The gap in the sternum, here at the bottom, this is called sternal foramen. It's a normal variant. This prominent area of activity here, I don't know if there's a name for it, but it's due to an unusual appearance, sort of a hook-shaped appearance to the inferior sternum, which is not uncommon. So they're just normal variants, and you don't need to worry about those. Okay, so we've spoken about metastases, but I just quickly wanted to mention primary bone tumours. We don't stage that many primary bone tumours with bone scintigraphy anymore, but some places we might still perform it for osteosarcoma, for example. So here is a patient with, this is a young man, I think he was about 15 years of age, who had an injury playing football, which was out of proportion to his, the severity was out of proportion to the injury. So we had an X-ray which demonstrated Codman's triangle. You can see elevation of the periosteum here. This is malignant periosteal reaction. So there's the bone, periosteum is elevated. This is the Codman's triangle, that's what it's called. This appearance here. That's a sign of malignant periosteal reaction, Codman's triangle. Here we can see the lateral view shows sun ray spiculation, a malignant periosteal reaction, with bone formation in the soft tissues in keeping with osteosarcoma. It's called sunray speculation because it bursts out like the sun, like this. Here's his bone scintigram, showing markedly increased activity, and I think, as far as I can remember, about 4% of patients do show bone metastases at presentation, so that's a good reason to perform it. But the point I just wanted to mention is we sometimes see skip metastases within the same bone. You can see a focal area of activity here. That's very important to identify if we're contemplating a resection for the patient. Of course, other metastases are absolutely critical as well, but I just thought I point this out. Be aware to look for skip metastases in the same bone. And we can actually see that one on the patient's MRI anyway, but of course we have to do our job and look at our scintigram carefully. Now I'm just going to finish up by talking about chemotherapy response assessment. This is a very, very important aspect of scintigraphy. So here's a patient who had prostate cancer and developed and came with a raised PSA, had a bone scintigram which identified a metastasis here, which we also saw in his CT scan. Notice some urinary activity here. This is the kind of contamination that we spoke about, that we mustn't mix up with metastases. We spoke about it in a previous talk. There's a photopenic defect here, which might be a hernia, perhaps. But in any case, the patient came with a bone metastasis, and because they were in a trial, we had quite a few scans to look at. So treatment was initiated. The PSA started to fall, but you can see that the area of increased activity, the area of abnormality within the spine on this subsequent bone scintigram 3 months later has markedly increased. 3 months after that, we can see that the activity is beginning to fall away here. And I think we have one more scan, which is either 3 or 6 months later, where it's very much diminished. So I just go back and show those again. You can see the patient was diagnosed with a bone metastasis, which we saw correlative CT imaging for. We gave them treatment. The PSA, I might say, actually fell during this time. The lesion became bigger, and it slowly faded away afterwards. This is called the flare phenomenon, or osteoblastic treatment response. And it's what happens is the bone lesion, as I mentioned in my previous talk, all bone metastases are lytic. The reason why they show as being lytic or sclerotic on a CT scan, or taking up tracer or not taking up tracer on a bone scintigram, is due to the relative activity of the underlying lysis and reparative osteoblastic processes. So that's why osteoblastic metastases show up so well on bone scintigrams. What's happened here is the patient has a metastasis in which we have some lysis and some sclerosis. We give the patient a successful treatment, and healing occurs with increased osteoblastic activity. On the CT scan, we'd probably see increased sclerosis in this area, which represents healing, not worsening of the metastasis. As time goes by, the osteoblastic activity reduces, the CT appearance won't change, the sclerosis will stay the same, and gradually the activity fades. Now, it's very important to understand that concept, and the reason is because we might have patients who have soft tissue disease, where the soft tissue disease improves, but a bone scintigram or examination of the bone windows on the CT scan, it looks as though the disease is actually worsening. Now, I'm going to just explain that by using a CT picture. Here is a patient with small cell carcinoma of the lung. They have extensive mediastinal lymphadenopathy. Looking at their bone windows, this area looks relatively normal, but there's a very small area of vague lucency here. You may not even see it. That's fine. So this looks normal. If we performed a bone scintigram, it would probably be normal. If we performed an MRI scan, we would likely see a metastasis here. So we will have reported this CT scan saying extensive nodal disease, no bone metastases. the patient received treatment and came back for a post-treatment scan. We can see there's been an excellent partial response to treatment within the mediastinal lymphadenopathy. And now, when we look on bone windows, we can see a very large sclerotic lesion. But this isn't a new metastasis. What this is healing of a previously largely occult little metastasis. Let's go back again and I'll see if I can convince you it's there. I'm by no means certain myself, but I think I can see a very vague lucency just in there. And that's undergone healing. This, if we performed a bone scintigram now, this would show greatly increased activity, reflecting the underlying osteoblastic reparative process. So it's very important that whether we're looking at a CT bone windows or bone scintigram, that we don't attribute this change in activity from here to here as being disease progression, if it could be due to underlying osteoblastic treatment response. So that's something you've always got to consider when a patient is commenced on treatment and you're asked to look at follow-up examinations. Okay, so I think we're going to call it a day there. I'm afraid that was a rather long one, but I hope it was useful. So next time we'll talk about some benign bone lesions which can cause diagnostic confusion. Thank you.